Okay, picture this. You've battled a bug, you're finally feeling better, and then bam, your joints ache, your eyes feel gritty, maybe it's painful to pee. It's like your body's gone rogue, hasn't it?
Absolutely. It's a really unsettling feeling. And that strange turnaround could actually be something called reactive arthritis.
Which used to be called Reiter's syndrome, right?
Exactly, yeah. And the weird thing is, it's your own immune system causing the trouble. The same system that just fought off, say, a stomach bug or another infection.
It gets a bit overly enthusiastic.
Sort of, yeah. It starts triggering inflammation in places you wouldn't expect: joints, urinary tract, eyes. Bit of a scattergun approach.
So for this deep dive, what we want to do is take some really solid revision notes on reactive arthritis and pull out the absolute must-know information.
The essentials. Making it clear, helping you remember it, without getting bogged down in overly technical stuff.
Exactly. We want those aha moments. So the sources revision notes, our mission is clarity and recall.
Think of it as your high-yield guide to reactive arthritis. Let's get those key facts locked in.
Okay then, let's unpack this. What exactly is reactive arthritis in simple terms?
Okay, so at its core, it's an inflammatory condition. And the classic textbook picture involves a triad of symptoms.
Ah, yes, the triad.
Arthritis, so joint inflammation. Urethritis, that's inflammation causing pain when you pee. And conjunctivitis, inflammation making your eyes red and sore.
So it's this inflammatory response popping up in different systems.
Precisely. And the key word is reactive. It happens after something else. Typically, it develops, say, 1 to maybe 3 or 4 weeks after a bacterial infection.
An infection where, usually?
Most often in the gut, the gastrointestinal tract, or the urinary system, the genitourinary tract.
And are there specific culprits, bacteria-wise?
Yes, definitely. We often see it linked to things like Chlamydia trachomatis, a common STI, or gut bugs like Salmonella, Campylobacter, Shigella.
Okay. And does it affect everyone equally, or are some people more likely to get it?
It definitely seems more common in men, particularly younger men, sort of in the 20 to 40 age range.
Right.
And it's classified as a seronegative spondyloarthritis. Seronegative just means standard blood tests for things like rheumatoid factor are negative.
Unlike rheumatoid arthritis.
Exactly. And it has a really strong link to a specific gene, HLA-B27. Something like 75% of people with reactive arthritis have this gene.
Wow, 75%. That's high. Definitely one to remember. HLA-B27.
Sure. And we can kind of subgroup it based on where that initial infection was.
Ah, okay. How so?
Well, you've got the post-enteric type, which follows those gut infections, Campylobacter, Salmonella, Shigella. And then there's the post-venereal type, often triggered by Chlamydia trachomatis, or sometimes it's seen in association with HIV.
Right, that makes sense. Post-gut bug or post-STI, essentially.
Pretty much.
Okay, so that's the definition. What about the etiology, the actual cause or trigger? We've touched on it, but let's dig in.
So the spark, as we said, is that prior infection. Gastrointestinal, like Salmonella, or genitourinary, like Chlamydia. That's the starting point.
But not everyone who gets, say, food poisoning gets reactive arthritis, right?
Absolutely not. Thank goodness. There's clearly more to it. Genetic factors are huge, especially that HLA-B27 gene we mentioned.
So it's like the infection pulls the trigger, but the genetics load the gun.
That's a good way to put it, yeah. It seems that in people with this genetic predisposition, the immune system just doesn't respond normally to that infection.
It misfires somehow.
Exactly. It mounts this abnormal immune response that leads to inflammation in the joints, the eyes, the urethra. And again, it's those specific bacteria, Chlamydia, Salmonella, Shigella, Campylobacter, that seem particularly good at provoking this reaction.
So it's not the bacteria setting up camp in the joints themselves.
Generally, no. It's more like the immune system is reacting to leftover bits of the bacteria. Or perhaps it gets confused and starts attacking the body's own tissues because they look a bit like the bacteria. The exact mechanism is still being figured out.
Okay. So who is most at risk then? We've mentioned genetics and the type of infection.
Yeah, so genetic susceptibility is definitely a major risk factor. Having HLA-B27 puts you at significantly higher risk.
Yeah.
We also know it's more common in males.
Right.
And logically, having had a previous infection with one of those trigger pathogens, Chlamydia, Salmonella, et cetera, that increases your risk too. It's like the immune system might be primed,
Primed to overreact the next time.
Intentionally, yes. So genes, sex, and infection history are the key risk factors.
Got it. Now let's get a bit deeper, the pathophysiology. What's actually happening inside the body at a biological level?
Okay, so it all starts with that immune response being triggered by the infection. The key idea seems to be the persistence of bacterial bits,
Bacterial bits. Like what?
like fragments of bacterial DNA or other antigens molecules that the immune system recognizes. Even after the main infection is cleared, these bits might hang around in the body.
Okay. Lingering evidence.
Exactly. And the immune system, particularly in someone with that HLA-B27 background, spots these lingering antigens and mounts an inflammatory attack.
But why the joints, eyes, and urethra specifically?
That's the million-dollar question, really. We don't fully understand why those sites are targeted. It could be that these bacterial antigens somehow deposit there, or perhaps there's some molecular mimicry where parts of our own tissues in those areas look similar to the bacterial antigens, confusing the immune system.
So the immune system attacks our own tissues by mistake.
That's the theory. It's an abnormal, misdirected immune reaction leading to inflammation in those specific tissues.
Okay, that helps clarify the how. Now, practically speaking, if someone comes in with symptoms like this, what else could it be? What are the main differential diagnoses?
Crucial question, because the symptoms can overlap with other conditions. Rheumatoid arthritis is a big one, also causes joint inflammation.
But that's usually symmetrical, right? Affecting joints on both sides.
Typically, yes, and often smaller joints. Plus, the blood tests are usually different positive rheumatoid factor, for instance. Reactive arthritis is usually asymmetrical and seronegative.
Okay. What else?
Psoriatic arthritis is another key differential. It can cause asymmetrical arthritis, sometimes skin changes like psoriasis, nail changes too.
Right.
And given the urethritis, you absolutely have to rule out an ongoing, active, sexually transmitted infection as the sole cause, like uncomplicated gonorrhea or chlamydia.
Makes sense. Any others?
Yeah, you'd also think about other spondyloarthropathies that family of conditions reactive arthritis belongs to,
Like
like ankylosing spondylitis, which mainly hits the spine, and enteropathic arthritis, which is linked to inflammatory bowel disease like Crohn's or ulcerative colitis.
Okay.
Then there are things like gonococcal arthritis, where gonorrhea does infect a joint gout, which involves crystals in the joint, septic arthritis, a direct bacterial joint infection, rheumatic fever. It's quite a list.
So careful history and examination are key.
Absolutely. And investigations help narrow it down.
Right. Before we get to investigations, what about how common this is? The epidemiology.
Well, UK prevalence figures are a bit fuzzy, but it's generally considered quite rare overall. We know it tends to affect young adults more often Caucasians, and as we keep saying, strongly associated with being HLA-B27 positive.
And the male predominance.
Yes, much more common in men. Some reports say the male-to-female ratio is over 10-1, which is pretty striking.
Definitely.
There's also been a noted rise in incidence among HIV-positive individuals in sub-Saharan Africa.
Interesting. And the main bugs again?
Chlamydia trachomatis is a big one, especially for the post-venereal type.
Cool.
Also chlamydia pneumonia. And for the gut-related ones, Salmonella, Shigella, Campylobacter. Don't forget Neisseria gonorrhea can be involved in maybe up to 15–16% of cases too.
So STIs are a significant factor.
They certainly are. And there's even some suggestion it could be transmitted sexually in non-travel related outbreaks.
Wow. Any other unusual links?
Well, there's a rare association with tuberculosis called Ponset's disease, and sometimes atypical organisms are implicated. More recently, there have even been reports of sacroiliitis inflammation of the sacroiliac joints in the lower back, appearing after COVID-19 infection.
Fascinating how infections can have these downstream effects. Okay, let's get into the clinical features. What does someone with reactive arthritis actually experience?
The classic triad is the thing to really look for: arthritis, urethritis, conjunctivitis.
Right, and there's a mnemonic for that.
Yes, a really useful one. Can't see, can't pee, can't climb a tree.
Ha! Okay, can't see for the conjunctivitis.
Yep, red irritated eyes, maybe some discharge. Can't pee for the urethritis.
Pain or burning when urinating.
Exactly. And can't climb a tree for the arthritis.
Because it often affects the lower limb joints, making movement difficult.
Precisely. Knees and ankles are common culprits. Large joints, usually.
That's a great mnemonic. Very memorable. Are there symptoms beyond that core triad?
Oh, definitely. People might get skin rashes.
Yeah.
There's a specific type called keratoderma blennoragicum, often on the palms and soles. Mouth ulcers are quite common too.
Okay.
Fatigue can be a big factor, fever sometimes. And the onset is typically about 2 to 4 weeks after that initial infection.
And the arthritis itself, you said asymmetrical.
Yes, usually asymmetrical, affecting maybe 1 to 6 joints, predominantly in the lower limbs. Less commonly, upper limbs or the spine can be involved.
What else might we see?
Heel pain is quite characteristic. Things like plantar fasciitis or Achilles tendonitis, which are types of enthesitis, inflammation where tendons attach to bone.
Ah, enthesitis. That's common in spondyloarthropathies, isn't it?
It is, yes. Nail changes can happen pitting or thickening. General constitutional symptoms like malaise, weight loss, sometimes more serious eye inflammation like uveitis. GI symptoms can linger, and rarely heart problems like conduction issues.
And how long does an episode typically last?
The acute symptoms often last around 4 to 6 months, but unfortunately, recurrence happens in about a quarter of patients,
Oh, right.
and maybe 10% or so develop chronic persistent disease. We can also see dactylitis, that sausage digit swelling of a whole finger or toe.
So a pretty wide range of possibilities. How do you confirm the diagnosis then? What investigations are useful?
Well, as we said, the diagnosis is mainly clinical, putting the story and the signs together. But tests are vital to support it and rule out those differentials.
Okay, like blood tests.
Yep. In the acute phase, inflammatory markers like ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, are usually high.
Showing inflammation somewhere in the body.
Exactly. But crucially, tests for rheumatoid factor and ANA, anti-nuclear antibody, are typically negative. That helps distinguish it from rheumatoid arthritis or lupus.
Right, the seronegative part.
Correct. The HLA-B27 test can be done. It doesn't diagnose it definitively, but a positive result increases the likelihood and might suggest a higher risk of recurrence or more severe disease.
Okay. What about finding the trigger infection?
Super important. So tests for chlamydia and gonorrhea are key, especially if urethritis is present or the history suggests an STI.
How are those done?
Usually with urine tests, NATs, nucleic acid amplification tests, very sensitive, or swabs from the urethra, vagina, cervix, throat, or rectum, depending on symptoms and sexual history. Culture might also be done, especially for gonorrhea sensitivity testing.
Right, gotta check everywhere relevant.
Definitely. Screening for other STIs like HIV, syphilis, hepatitis B, C might be done based on risk factors, sometimes testing for Mycoplasma genitalium.
Okay.
If there's significant joint swelling, joint aspiration is important.
Sticking a needle in the joint, why?
To get a sample of the synovial fluid, you analyze it to rule out septic arthritis, a direct bacterial infection in the joint, or crystal arthritis like gout.
Ah, I see. Makes sense.
You might also do blood test serology looking for antibodies to gut pathogens like Salmonella, Shigella, Campylobacter, Yersinia if a gut infection seems the likely trigger. Maybe a TB test in relevant populations.
What about imaging, x-rays, scans?
X-rays are often normal early on, but in chronic cases they might show joint damage or bony changes, particularly around the sacroiliac joints or heels. Ultrasound and MRI are better at showing active inflammation, synovitis, enthesitis, sacroiliitis.
So they can see the inflammation directly?
Yes, they're more sensitive for soft tissue and early inflammatory changes. Sometimes a bone scan scintigraphy is used, and an ECG might be considered in long-standing disease to check for those rare heart conduction problems.
Wow, quite a workup, potentially.
It depends on the presentation, but yes, you need to be thorough to confirm reactive arthritis and exclude other serious conditions. It's really a combination of clinical picture, history, exam, and targeted tests.
Okay. So once you've landed on the diagnosis, how is reactive arthritis managed? What's the UK approach?
The main goals are, 1, treat any ongoing infection that triggered it, 2, relieve the symptoms like pain and stiffness, and 3, manage the inflammation to prevent damage.
Right, so antibiotics first.
If there's evidence of an ongoing trigger infection, like active chlamydia, then yes, antibiotics are given, though how long to give them for, especially if the initial infection seems cleared, is actually still a bit debated.
Okay. What about the arthritis and pain itself?
First line for that is usually NSA, non-steroidal anti-inflammatory drugs. Things like naproxen or indomethacin are often used to reduce pain and inflammation.
Standard anti-inflammatories. And if they don't cut it?
Then corticosteroids are the next step. These can be injected directly into a particularly troublesome joint and an intra-articular injection. That works well for, say, an inflamed knee or sacroiliac joint.
Targeted release.
Exactly. Oral steroids-taking tablets are usually reserved for more severe, widespread symptoms, or if NSAIDs aren't enough, or if there's significant eye or rarely heart involvement.
Okay. What if it keeps coming back or becomes chronic?
That's when you consider D-Arner's disease-modifying anti-rheumatic drugs. The main ones used in reactive arthritis are sulfasalazine, which has some decent evidence, and sometimes methotrexate if sulfasalazine isn't effective or tolerated.
So these aim to calm the immune system down long term.
That's the idea, yes. to reduce flares and potentially limit joint damage over time. The experience with them isn't as extensive as in rheumatoid arthritis, but they can be beneficial.
And for really tough cases.
For very aggressive disease, or if it's evolving into something more like ankylosing spondylitis, then biologic drugs, specifically TNF-alpha blockers, might be considered.
Yeah.
But that's usually under specialist care.
Right. So lots of medication options. What about non-drug treatments?
Absolutely vital. Physiotherapy is key.
What does that involve?
Exercises to maintain or improve joint range of motion, strengthen the muscles supporting the joints, reduce stiffness, and help with things like enthesitis that heal pain.
Makes sense. Keep things moving.
Yes. And in the acute phase, resting the inflamed joints helps. If there's a large effusion, lots of fluid buildup in a joint, aspirating it, draining the fluid, can provide significant pain relief.
So it's a multi-pronged attack.
Hmm.
Infection control, symptom relief with NSAID steroids, potentially DMARDs, plus physio and rest.
Exactly. A holistic approach tailored to the individual symptoms and severity.
Okay. So what's the overall outlook? What's the prognosis generally like for someone with reactive arthritis?
It's quite variable, honestly. The good news is that for many people, symptoms do improve significantly, often resolving within, say, 6 months to a year.
That's encouraging.
It is. But as we mentioned, some people do experience chronic symptoms that persist long-term, or they might have recurrent flares over the years.
Right, at 25% recurrence rate.
Yeah. So while many do well, it can become a longer-term issue for some. Getting early diagnosis and proper treatment is really important for managing symptoms effectively and hopefully minimizing any long-term problems.
Which brings us to complications. What are the potential long-term issues if it's not managed well, or if someone has chronic disease?
The main ones relate to persistent inflammation. Chronic joint inflammation can, over time, lead to damage to the cartilage and bone, potentially causing joint deformities and long-term pain or disability.
Okay. What about the eyes and urinary tract?
Chronic or recurrent eye inflammation, like uveitis, can be serious and potentially affect vision if not treated properly. Conjunctival scarring is possible. Similarly, persistent urethritis or related inflammation could lead to urinary tract problems.
Any other rarer complications?
Very rarely, as mentioned, there can be cardiac involvement, usually affecting the heart's electrical conduction system. Lung involvement is even rarer. But these highlight why ongoing monitoring is important, especially in chronic cases.
Definitely. Prevention and management are key.
Absolutely. Mitigating those risks is a major goal of treatment.
Okay, so let's try and summarize the key takeaways for reactive arthritis. It's this inflammatory condition kicking off after an infection.
Right, usually a GI or GU bacterial infection. That reactive element is crucial.
Characterized by that classic triad arthritis, urethritis, conjunctivitis, remember, can't see, pee, or climb a tree.
Perfect mnemonic. And it often affects large joints in the lower limbs asymmetrically.
More common in young adults, particularly men, and strongly linked with HLA-B27.
Yep. And remember, it's seronegative. Those standard rheumatoid blood tests are negative.
So definitely something to have on your radar when a younger person presents with that kind of symptom cluster, especially if they've had a recent infection.
Exactly. It's a fascinating example of how the immune system can sometimes go awry after doing its job.
Which leads to a final thought, perhaps. Considering how the body's defense system can misfire like this, what other conditions out there might share similar underlying immune mechanisms? Something to ponder.
A very interesting question indeed. The interplay between infection and autoimmunity is a huge area.
Well, hopefully this deep dive has helped clarify reactive arthritis. For anyone revising for the MSRA or just wanting to learn more, do check out pastthemsra.com.
And freedesray.com for some great free resources too.
Thanks so much for joining us in exploring reactive arthritis today.